the other JC, Dr. Jay Crutchfield from SOMA today, presenting Colorectal Cancer for Dummies. This is Still Healthy for the month of March. They had one this week in Kirksville as well that you'll be able to get online. As always, these are recorded for Blackboard, and we upload them to iTunes if you ever want to watch them later. In April, the next one, we'll be talking about 3 different devices that are personal devices for exercise. One is the Fitbit, the second is the Nike Elite, and the third is the Jawbone Up. All personal devices that you wear that measures your steps and those types of things. So that will be April. That's going to be the upcoming one. But without further ado, this month is actually Colorectal Cancer Awareness Month, and we have Dr. Crutchfield presenting about that for us. So thank you.
Thank you for coming. I see that you didn't have anything else better to do in your lunch hour. So the reason that we're doing this is not really just because Tanya asked me to do it, because she's probably going to ask you guys to contribute next month. But it turns out that we are in Colorectal Cancer Awareness Month. So everything you need to know about colorectal cancer is going to be in this lecture. And I did choose this site here, the American Society of Colorectal Surgeons, because the internet is loaded with sites which have lots of not accurate information. So I chose this particularly just to make sure that if you have questions or if you get the handout that you go to a reputable site to go. So in this time that I have, we're going to talk about the anatomy, colon, rectum, and anus, and why that's actually important. We're going to talk about why that anatomy and the understanding of the anatomy is important to how we diagnose it and treat colorectal cancer. Talk about some of the myths, things that people believe that might be inaccurate, and especially if you go to some of the websites. And I'll just tell you one of the myths right away. Colon cleansing from your local let's go get an enema or a coffee enema is probably not the right thing to do. Bowel preps, for those of you who have had a colonoscopy, you know what I'm talking about. For those of you who have never had a colonoscopy, we'll talk a little bit about the bowel preps. Talk about colon polyps, why they need to be removed and which ones need to be removed. We'll talk about the actual procedure. And what if you don't want to have a colonoscopy? What about this new virtual colonoscopy that everyone is talking about? And then we'll talk a little bit about health insurance and what it means to have a screening exam and what it actually means to have a screening exam and whether or not your insurance will actually pay for it. So, a couple of things. My audience is really directed towards those of you who are not clinicians who don't deal with this all the time. Don't use any of the information here to self-diagnose. We're not going to go through all the epidemiology because Tanya sent all the epidemiology out in your email. It's actually all there. And we're not going to talk about all the surgery because it's just too voluminous for an hour. And we're not going to talk about all the treatment, but we're going to hit the high points of all of this. So, what is colon cancer? By the time that we're done, hopefully you'll understand what this is and how we treat it and why we treat it the way we do. What is the colon? Where is the colon? Is colon cancer the same as rectal cancer? And is rectal cancer the same as anal cancer? And I'll give you some examples of how this is treated in some famous people who have been affected by this. Who gets it? What are the risks? And am I at risk? How does it spread and how is it treated? So hopefully your brains will be saturated by the time that we're done. For those of you who don't know, this is Sharon Osbourne and her husband Ozzy, who's the rock singer. Sharon was diagnosed with colon cancer a couple of years ago and had a colectomy. If you actually have access to this PowerPoint, you can click on the links and you can go listen to Ozzy sing. Our age group will remember Elizabeth Montgomery, who was bewitched. Please tell me that most everybody in here has heard of this show. Thank you. Now, Ronald Reagan didn't really have colon cancer, but he actually had 2 operations in his life which he actually didn't need. And he had 2 operations because he was the president. So think about this if you want to run for public office. When Ronald Reagan got shot, he had a thoracotomy, and he actually didn't need a thoracotomy. because all he needed was a chest tube, which would have taken care of it. And the surgeons that operated on him have told this story many times. And the reason that they decided to open his chest and go get the bullet was to make sure, just to make sure that nothing else had gone wrong, because he was the president. Had that been you or I, we would have got a chest tube and been sent home in 3 or 4 days. In terms of colon cancer, he had a polyp that had some malignancy in it, and because of that, all he needed was to take out the polyp, which they did. But because he was the president, they decided to take out that piece of colon too. We know about Farrah. When I was in 7th grade, I was in love with Farrah Fawcett. All the guys in here were in love with Farrah Fawcett too. It just didn't matter. Just raise your hand. You guys are all in love with Farrah died because she was diagnosed with anal cancer, and we're going to talk about her treatment here in a little bit. But Farrah didn't have to die, and that's actually what's sad. And of course, we know about the Gibb brothers from the Bee Gees. The two younger brothers here are actually fraternal twins, and they both died of colon cancer. And recently, I think, I'm going to get the name wrong, but I think that it was Barry. No, Barry's an older one. So Robert and Bill Reeves, I can't remember. But just within the past year, one of them died. And it's never been 2 or 3 years ago before the other one died. So if you want to click on the music, you can. I'm not going to do that here in the interest of time, but if we wanted to do a little disco, we could do it. So stats, Tanya gave you some of this. Colon cancer is the 4th most common cancer, behind skin cancer, prostate cancer, breast cancer in women, which is number 2, lung cancer, and then number 4 is colon cancer. So lots of people will be diagnosed with it, and lots of people will die with it. These are estimated numbers that are extrapolated. Let's talk about the colon. Where is it? For those of you who don't know where the colon is, it's inside your abdomen. And normally we think about it in 3 parts: ascending colon, transverse colon, and descending colon. There are other areas, but for our talk today, if you know this much, it'll get you through what you need to know. And then there's the rectum. We bring this up separately because the anatomy of the rectum and the anus are considered different, especially in the operating room, for how we treat colorectal cancer. So let's talk a little bit about how this is arranged inside your abdomen and why this is important, because if you understand the anatomy, it'll make sense when we talk about the treatment later. First of all, the abdomen, if we think of this trash can as representing the abdominal wall, and none of the anatomists in here can start laughing, but this is what we're going to think of it today. So the trash can is the abdominal wall, and the abdominal wall is made of musculature. So inside that, we have a lining inside the abdomen, and that's called the peritoneum. So think of the trash bag getting ready to line the abdominal wall as the peritoneum. So when you hear terms like so-and-so died of peritonitis, or they had bad appendicitis, ruptured appendicitis, and they had peritonitis, it's the lining inside the abdomen which has become inflamed from all the pus. So here, and I'm going to explain this in just a minute, this is where the colon actually begins to form. It's like getting shrink wrapped. This will make sense in just a second. And the colon polyps occur here on the inside lining. They don't occur outside the colon, they occur inside the colon on what we call the mucosa. So this is sort of how the colon forms inside the body. It's like you're getting partially shrink wrapped. So the colon is the man here pushing through the shrink wrap, and then as we shrink wrap him, as he continues to walk forward through the plastic then will wrap around behind him. So this shrink wrap is called the peritoneal line. I actually asked Dr. Robinson to take a picture of my abdomen. Sorry. Why the hell are you guys laughing? I don't understand. That's me. But anyway, so here is the abdominal wall. Okay, and inside is the peritoneum, which is the lining, and then the colon is actually pushing through this peritoneal lining right here, and will eventually, as the shrink wrap forms, it will shrink wrap around and behind the colon, and this becomes important in how we treat it. So here's the colon. This is the way it looks. inside the body, the right colon and the left colon are fixed. So when the colon pushes through this shrink wrap, it actually becomes permanently fixed to the abdominal wall here and here. And this is the portion of the colon called the peritoneal reflection that determines from the portion of the colon now that goes into the rectum. So the portion of the entire colon, which is the portion that is covered by the peritoneal lining, down to the pelvic floor, this is colon. And this is colon cancer will form in here. Any cancer that forms in here will be rectal cancer, and of course if it forms down lower, it will be anal cancer. This is treated. It depends. You have to know this anatomy in order to know how to treat it. Because colorectal cancer is not the same as colon cancer. It's all different because it's treated differently. So here's what it looks like on the inside. And as you can see, the transverse colon is sort of free and floppy, whereas the ascending colon and the transverse colon are fixed. They're fixed to the side wall of the abdomen. And it's only because of this fixation here that we can actually do a colonoscopy. If the entire colon was sitting free and floppy, it would be very difficult to do a colonoscopy. The fact that the colon is fixed here actually helps us. So when we pass the scope up through the rectum and in through the colon, it helps hold the scope in place. And this will make sense a little bit later. Again, we're kind of beating a dead horse here, but this is the peritoneal reflection. At that line, everything above it is colon. Everything below it is rectum. Now, from a non-medical point of view, the portion of the colon which has these valves in it would, in theory, all be called the rectum, because this is where storage of feces and poop and stuff is right here. So, from a non-medical layman's point of view, all of this could be considered rectum, because it stores the feces before we evacuate. But anatomically, and for us in the operating room, the colon ends right here at this line, where the peritoneal reflection, i.e. the shrink wrap. This is the shrink wrap around the colon. Where it ends down in the pelvis is where the colon is. So again, we have the anus even down further. And colon and rectum are made up of the same sort of mucosa under the microscope. It looks the same. That is not true of the anus. So everything below what's called the dentate line. Someone named it the dentate line here because they thought it looked like teeth. I don't see that. I'm not sure how they came up with that. But from this point down, we consider this to be anus. Now, why do we care? Because anal cancer is treated differently than rectal cancer, which is treated differently than colon cancer. So here's the way it looks. If I were to take you and bisect you down the middle, what you would see is, here's the shrink wrap, right here, here's where the shrink wrap ends, and then everything below the shrink wrap is considered rectum. And then this is, of course, anus. So here it is in a female, here it is in a male. So here's the shrink wrap, this is the peritoneal reflection. So when we're in the operating room, we will dissect down here to the peritoneal reflection to get access to the rectum. Now, anatomically, clinically, in layman's terms, you'll find different definitions, but as a surgeon, this is our marker in the operating room for where the rectum begins and for treating you. Here, the levator ani is the muscle that allows you to hold your poop or not, or to relax the sphincter mechanisms that allows you to go to the bathroom. But the reason that we care is because everything we do in colorectal cancer surgery is designed to maintain continence. We want it so that when we're done with your operation that you can still poop and that you can still control your poop. Because if you can't control your poop, if I damage the anal sphincter, if I damage the muscles down here, then what good does it do for you to walk out of the operating room and poop your pants every time you sneeze? If I've destroyed this, so I've left it intact, but the muscles don't work, I've done you no favors. So everything we do in the operating room is designed to save the sphincter. Okay? Is colon cancer the same as anal cancer? No, just a close-up view. Again, here
is the peritoneal reflection. This is where we would dissect down to in the operating room. And then below this, from here to here, would be considered rectum. Now, in terms of storage of poop, from here up to here would be considered rectum, but in the operating room, like I said, it's a little different. Anal cancer is not the same as rectal cancer. It's treated significantly different, and I'll show you that. Here, because of this lower aspect that is below the peritoneal reflection, we can treat rectal cancer with radiation therapy first. It's because of this area here and the peritoneal reflection that rectal cancer is treated usually first with radiation therapy. So hence the phaser down here. It's not really the way it works, it's right here. So we can radiate this portion here, and the reason that we radiate people with rectal cancer or anal cancer before surgery is to try to shrink the tumor and make it easier to resect the tumor so that we can save the sphincter muscles. It's all about making you continent so that we don't have to give you a colostomy. And I'll show you a picture of that a little bit later. So again, colon cancer can be treated just with excision. Colon cancer does not usually get radiated. So any of the tumors that are up in the colon, people who have that don't usually get radiation therapy. They might get chemotherapy, but they won't get radiation therapy. If you have a tumor in the rectum or in the anus, we give you radiation therapy first and chemo to shrink the size of the tumor so that we can resect it and hopefully save the muscles here. Save it so that we can become continent. Tommy.
Is that because it can be localized radiation and not whole body radiation?
Yes, radiation is a good question. Is it because the radiation can be localized and not whole body radiation? All the radiation that you get today is usually going to be localized. There's even radiation therapies today, so for example, proton therapy, which is the most expensive medical therapy we have in the United States. It can actually be aimed at this region. How does the radiation oncologist, how does he determine where the peritoneal reflection ends and the rectum begins? We do that sometimes using either colonoscopy or barium enema, and we can use that information to localize where we're actually going to shoot the radiation beams. So again, rectal cancer, anal cancer, we usually give chemo and radiation first. Colon cancer, that's not usually the case. So risk factors, who's going to get colon cancer? People who have long-standing ulcerative colitis are at a risk to develop colon cancer. So if you have long-standing ulcerative colitis and it's not responsive to medical therapy, we would recommend that you get a total proctocolectomy, where we remove the colon down to and including the anus also. It's a tough procedure. And as you can imagine, a lot of those people end up with either colostomies or ileostomies. Genetics, we know a first degree relative puts you at a higher risk to develop colon cancer. We also know the older you are, the higher risk you have of developing colon cancer. And of course, whether you've had polyps, we know that if you're fat, if you smoke, and we think that a diet high in fats can contribute to this, but depending on if you read Yahoo or Google or MSN, depending on what you eat can cause any type of cancer. So that's sort of debatable, whether you actually trust that. So how do we know if we should worry about whether you should have colon cancer screening or not? Anybody who comes into my office and says that they have blood in their stool gets a colonoscopy. Anybody. If you're 15 years old and you have blood in your stool, you come to my office, you're getting a colonoscopy. It is a mistake to tell somebody, regardless of age, that blood in your toilet is from hemorrhoids. You see it all the time. Every surgeon has stories to tell you of the 20-year-old kid who comes in, has had blood in his stool for 3 years, and has been told that it's hemorrhoids, only to find out later that it was colon cancer that's now spread to the liver or it's locally metastasized. So anybody, I don't care how old you are, if you're 10 years old, you're going to get a colonoscopy. That's just the way it is. If you think that if you have severe anemia, and you have to look for the source of why you're anemic, the source of blood loss, I also recommend a colonoscopy. Pain, blood, or itching is also, at least at a minimum, you should have an examination of the anal area, perhaps a digital rectal exam. But I would go as far as to making sure that there's no pathology or disease in the entire colon. Human papillomavirus is a risk for developing anal cancer, although not all anal cancers come from HPV. Bloating and unexplained weight loss. So back to how does the radiation oncologist tell us exactly where he's going to fire that beam? Sometimes I'll use an old-fashioned test called a barium minimum, and it's exactly what it sounds like. You go to the radiology suite, they put a little tube up your butt, they blow you full of barium, and they take x-rays. And this is an old-fashioned test they used to use before the advent of colonoscopy, which means it was used very frequently before the 1960s. And we still use it. But sometimes, depending on this area down here, this is not a good image of it. The radiation oncologist will look at this if you have a rectal cancer, and he'll know at what point and how high and how much of the radiation therapy to give you and at what level based on this. There are other ways of doing this also. Now, with my own patients, I always videotaped their colonoscopies and gave it to them. Whether they chose to watch it or not is another matter. I don't really care if they watched it. But if they end up having significant pathology and had to go for another exam or another colonoscopy or more biopsies, or they had to see a specialist, they always have a video of the findings that I have. So here is typically what we call the apple core lesion. This is a colon cancer seen on barium minimum. So the cancer is actually, of course, here and here. And this is the portion of the colon which is open and the person's pooping through this narrow level. So right here is the amount this person's pooping through. So you can see that that's not a very big lumen. That person's pooping through something maybe the size of a pencil. So this is when someone comes in and they say that I'm kind of bloated. I don't feel good, sort of bloated. Every time I eat, I get really bloated. That can be a sign of gallbladder disease, ulcer disease. It can also be a sign that your poop's not passing, that you're bloated because the poop can't make it out through this small open narrow here, an apple core lesion. Pretty classic picture of an apple core lesion. So, I love this ad I found. So our general rules for colonoscopy. Your first colonoscopy, assuming that you have no family history, is going to usually be at the age of 50. If you do have a family history, we recommend that the first colonoscopy be 10 years before the age of the relative, the first degree relative we have. So if my father had colon cancer at the age of 30, I get my first colonoscopy at the age of 20. Does that make sense? 10 years before. So if your mother had it, she was 45, you're going to get yours at 35. And there are exceptions to all of these rules. These are not hard and fast, but it's just an exception. And of course, if you have polyps, depending on the pathology of that polyp, that will determine when your next colonoscopy is. So you might have your first colonoscopy at 50, and then depending on the type of polyp that you have, that will determine when you get your next colonoscopy. Usually, if it's normal, 10 years. So your first one's at the age of 50, so you know family history, the age of 50, and then your next one is going to be at the age of 60, assuming that you have no other indications. Now, let's say between the age of 50 and 60, you have blood per rectum, or you have a little anemia. You just bite yourself another colonoscopy. You can't ignore the fact that just because you had a colonoscopy doesn't mean that you're free and clear for the next 10 years. That means statistically you're free and clear for the next 10 years. There are exceptions to everything that I'm telling you. So what about the bowel preps? Back in the 50s and 60s, they used to use magnesium citrate. High magnesium, low is hard on the kidneys. They would mix it with some Docalac suppositories, drink it with a lot of water, lots of problems with kidney problems, kidney failure, high magnesium levels. And then this one came out. This is called Go Lightly. Go Lightly is the one that gave it a bad name because it's a salt solution, and they actually came out with another version of this called New Lightly, which you could add a flavor pack to it. And you could add strawberry or lemon, and I don't remember what else, but it still tasted pretty nasty. So, what I used in my office was this. I used the tablet prep called Osmo Prep. Now, there's like 20 tablets you have to take, but taking tablets is a lot better than having to take a big gallon jug of the Go Lightly or the New Lightly. And I always let my patients take it with Gatorade if they wanted to. Some of your gastroenterologists don't want this because they're afraid that a patient will take it with the red colored Gatorade, the cherry one. But I can tell the difference between blood and red Gatorade. That was the concern, is if you take it with red Gatorade and I'm doing your colonoscopy and I see red fluid, oh my God, you're bleeding to death. No, I mean, you can tell the difference between Gatorade and blood. But that's really why. So, is the prep that bad? The answer is, in my opinion, today it's not as bad as what it used to be 10 years ago. And I really got away from prescribing a Go Lightly. I find that the older patients can't handle this. Older patients can't handle this volume load, and the preps were really bad. When I first started in practice, we used to actually admit patients to the hospital the night before and have the nurses give them their preps. And what we found is that the preps were usually pretty bad. People like to use their own toilets and prep themselves. And once we let people start doing it at home, we actually got better preps. Now, that is not the reason, though, that we started letting people do it at home. As you can imagine, if a patient came to the hospital the night before, there was a hospital bill. So insurance companies really didn't want to pay for the pre-evening stay in the hospital. But it turns out that this is a good thing. So, no, this is not a colonoscopy. That's an amazing photo. That's hell some Photoshop right there. That's amazing. So what is a colonoscopy? Colonoscopy is where a flexible scope goes up through the entire colon, through the anus rectum, up through the entire colon, down into the cecum. And sometimes we can even get the scope into the terminal ileum, the small bowel. Like I said, I used to video all of mine so that the patient could always see the results afterwards. It's actually a pretty complicated head on the colonoscope. You have a suction chamber, you have an instrument chamber, irrigation, lights, motorized irrigation, and then here's what it looks like on a patient who's had an x-ray on the table of the colonoscope up into the colon. Thank God that the descending colon and the ascending colon are fixed, because all of us who have done this have found patients where we cannot get down into the entire ascending colon, into the cecum. Your colonoscopy is not complete until your gastroenterologist or surgeon has seen the entire colon. If you have a colon that does lots of loops, lots of folds and bends, and they can't get the scope all the way through, then I would send you back and have them do a barium enema on you. We have to do something to look at the entire colon. Whether we do it with an x-ray, barium enema, or whether we do it with a colonoscope. Sometimes I might even have to send you to one of my buddies and let him try it later if I think that they might have better luck. So I'm going to try to see if I can play this. What if you don't want a colonoscopy? What about this new thing called virtual colonoscopy? Not meant for everybody. Usually older patients who are on blood thinners. So in order to have this done, you take the bowel prep the night before, they put a small tube into the anus and blow you full of air. Then they run you through the CAT scanner. And as you can see this right here, this is a polyp. I'll move back here and show it to you. That's a polyp. So this patient just bought themselves a colonoscopy. So right away you can see the disadvantage to this. If you're 95 years old, you're on a blood thinner, you're at high risk to have a colonoscopy, this procedure might be fine for you. But if you're 18 years old or 40 years old and you're just afraid of having a colonoscopy, probably not, because if you find a single polyp, you're going to have the real thing so we can go and biopsy that polyp. So there's another polyp, here's another little polyp. And it's not just a free ride in the CAT scanner. They actually blow air up into your colon to distend the colon. So there's some discomfort with this. They don't use sedation with this. And besides, your insurance company won't pay for that for you to have sedation. So, let's go polyp hunting. Different kinds of polyps are going to determine what your follow-up is. For example, here's hyperplastic polyps. These are completely benign, and I can diagnose those just from looking at them. The other ones, I can't tell you 100% what they are. I need a microscope and a pathologist to tell me for sure what these are. But we do something called chromoendoscopy, where we can paint the polyps. So this helps us determine what kind of polyp they are.
In this procedure room, Dr. Navtej Buttar uses a colonoscope to look for signs of colon cancer or pre-malignant polyps.
I can see a small polyp right there.
The white light gives a pretty good view, but because this patient is at high risk for colon cancer, Dr. Buttar sprays a blue dye onto the colon wall. It's a technique called chromoendoscopy.
Chromoendoscopy is a twist on routine endoscopy.
Dr. Mark Larson says the technology may make abnormalities and early colon cancers easier to detect.
There's an abnormal surface, let's say there's a polyp or a cancer in a background of otherwise normal tissue. The staining or colors will highlight that area.
It's sort of like looking for fingerprints on the surface of a car. You might not be able to see them with the naked eye or with a flashlight, but after dusting with powder, they reappear.
Right in the center of the whole screen is that polyp there that is a little bit more prominent because of the contrast.
Polyp is right here.
Dr. Larson says the jury's
Right, let me back that up so that you guys can see that.
More prominent
Polyp is
because
right
of the
there.
contrast created.
Dr. Larson says the jury is still out on just how effective chromoendoscopy is. He says for routine exams, it may not be better at screening than normal endoscopy. But researchers are looking at the possibility that it may make a significant difference in patients who are considered to be at higher risk for developing colon cancer. For Mayo Clinic News Network, I'm Vivian Williams.
So painting the polyp can help me determine whether or not, especially if it's a difficult polyp to get to, whether or not I actually have to take it out, or whether I can just cauterize it. So there are different types of polyps. How do we know how soon and how often you need a colonoscopy? Well, going from relatively benign to cancer, polyps follow this cascade, I think is probably the right word, of benign hyperplastic polyps to any type of polyp that has a villus component. A villus component will look sort of like, this is a large villus adenoma, but a villus polyp has these little fronds on it. And when we paint these with methylene blue dye, we can see these little fronds. And I can be pretty sure just from the size of this one that it needs to come out anyways, and from the size of this. You can see that this is called a pedunculated polyp. Here's a polyp, this is a mushroom. We'll actually take the snare, put it around the polyp, and use cautery to remove all of these and send it to the lab. So whenever we have a villus component, it has to come out. Why is this important? Let's say that I'm doing a colonoscopy and I remove most of this polyp, but I don't get the whole thing, because that does happen too. My pathology comes back and says it's a hyperplastic polyp. I don't care. Now we can wait 10 years for your next colonoscopy. But if I take part of this out and it comes back as a villus adenoma, we're going back. And we're going back probably tomorrow or as soon as you can scan the next bowel prep, and I gotta get the rest of that thing off. Because this has a 75% chance of turning into a colon cancer. So this is the pathology report, and I always like to give a copy of the pathology report to the patient along with a list of this in my office so that they can look at the list and see exactly which kind of polyp they have. Patients are not always as dumb as we think they are. They can actually remember a lot of this. It makes it so much easier. If you move across country, you've had your colonoscopy done back in Connecticut, you come back to Arizona, patient walks in and says, I had a villus adenoma. Makes my job so much easier. Because instead of a 10-year interval, they're going to have a 5-year interval. Anybody that has any of these polyps here, 5-year interval in between colonoscopies. And the argument could even be made here, we could go 7 years for this one. And there's a lot of this is very subjective. You'll find readings that will argue this and give you different numbers. But in my practice, that's what I follow. Yeah.
Okay. So can a person have different kinds at the same time?
That's a great question. I'll show you a video here in just a minute of a patient of mine who has multiple polyps of multiple different kinds. And the colonoscopy then is determined by the most evil of those polyps. So if you have 25 hyperplastic polyps and you've only got one villus adenoma, you just bought yourself another scope in 5 years. Here, 10 years. Yeah.
More of a physiology question probably. But so they're all called adenomas. Does that mean there's a common type of precursor
Yes.
cell?
Yes.
So,
Adenoma cell, yes. It comes from the lining of inside the mucosa, which brings us to the next.
that's what
Brings us to the next slide. So in this progression, polyps begin in aligning in the surface of the colon, inside the mucosa, and until they're at a stage 3, and let's put this up here. Surgeons like to use something called the Duke staging, A, B, C, and D. The one that is going to require that you're going to get chemotherapy is right here, is if you have any lymph nodes that are involved. If we take your colon cancer out, and you are a Dukes A or a Dukes B, where it's grown through the lining of the mucosa, and perhaps into either the muscularis, or even touching into the serosa. This is the shrink wrap. So the outer line here, this is the serosa, also known to us as the shrink wrap. This is the visceral peritoneum here. If it grows into and touches that, no chemotherapy is necessary. But if you have lymph nodes that are positive, you're going to get chemotherapy. Now, exceptions to this. If a 25-year-old kid comes in and he has an A or B, he's going to get everything because he's young. We're going to give him chemotherapy just because he's so young. We want to make sure we haven't turned anything behind. But if grandma comes in and grandma's 95 and she has an A or a B, she's not going to get chemotherapy. So the younger you are, the higher the chance are that you're going to get chemotherapy. If you have lymph nodes that are positive, you're going to definitely get chemotherapy. But this is subjective. Again, it's going to depend on your age, the size of the tumor. What if, for example, we have a Dukes B tumor right here, but the thing is as big as a softball? The oncologist might say, well, I would recommend that you go ahead and do chemotherapy. So that's, it's not all hard science. So some of my patients that have offered to serve for Dr. Critchfield's Academy Award-winning movies, let's go to the good one. This might be, let me show this one real quick. This is a patient of mine who had rectal cancer. This was a 45-year-old lady who came to see me complaining of blood in her stool for about 2 years, and it had been kind of blown off as hemorrhoids. So immediately when we put the colonoscope in, we can see that she has a large rectal cancer that's bleeding. And once the motion stops here, you'll see there. So the entire, all of this here is the cancer. All of this here is the cancer. And this is in the rectum. It's not anal cancer. So this patient is best treated because it's below the peritoneal reflection. She's going to get radiation and chemo first to shrink the tumor, because this tumor is probably maybe 1 or 2 centimeters away from the musculature and the distal anus. So I'm going to do everything I can with this patient to make sure that when I'm done with the operation, that she is continent. So that when I'm finished hooking her up, when she sneezes, she won't poop her pants. Now here, I'm just taking out some other polyps. These are benign hyperplastic polyps, so all I'm doing is cauterizing these.
So, question.
Yes, sir.
So you, the gastroenterologist is experienced enough to identify those benign polyps just from the visual morphology?
Yeah, that's fair. After you do enough of these, about the only polyps that I can tell you with 100% certainty that I know what they are hyperplastic.
And do you
But
take
the other ones
a
I'm never
chunk
sure.
for biopsy?
I
or
can biopsy them.
So you
Yeah.
still have
I
that.
will biopsy and
Oh.
fulgurate at the same time.
Uh-huh.
And then we take note of where this level
Sure.
is at.
Uh-huh.
That's a good question.
Yeah.
So to just go in and fulgurate is the wrong thing
Yeah,
to
yeah,
do.
yeah.
Because you need the pathology
Yeah.
also. So let's come up here, because it's bleeding really, it's quite friable. So this is a pretty significant rectal tumor. Here I'm taking biopsies. See the edge here is really curled. So let's go back one more here and show you. So here is a patient who has multiple types of polyps.
What percentage of patients have multiple?
I would say 40%, probably.
And is that because they waited too long to get the colonoscopy?
I think it's just bad luck. I think it's partially genetics, partially bad luck. You know, we're not at the point where we can predict it yet. Here's the polyp. So I injected that submucosally with some saline to elevate it. Now I'm going to put a snare in. Here's the polyp right there. Probably hyperplastic. And then we'll cauterize. And then I suck it up into the scope. So then I suck it up into the scope, and then it goes into what we call a specimen trap. We wash it through with fluid and water, and then the specimen will collect in a trap that goes in and follow. So here's another polyp. Again, I don't know what kind this is. So here we use a Varix needle, which is also the same type of needle that we use to inject varices of the esophagus or your veins and your lower extremities and legs. So we will inject, raise it off of the underlying submucosa. Biggest complication of colonoscopy is perforation of the colon. We poke a hole in the colon.
How often does that happen?
The statistic is 1 in about 1,000. So it's uncommon. So here the same thing, injected it. We'll suck that into the trap. And now let's go down to the really good stuff. Okay, so here's a larger polyp down in the rectum. Same patient, large polyp in the rectum. Placing the snare around it, and I have to make sure that I get the entire polyp down to and including some of the stalk. Because there can be cancer cells even down into the stalk. So here we're taking the polyp off. And it leaves a pretty large defect. And at this point, I wasn't exactly sure if I had gone too deep. I know I'm not perforated it through the colon, but I'm not sure how far into submucosa or even muscularis that I've gone, because you can see muscle fibers here. So the lucky thing is because this polyp's in the rectum,
if I did perforate this colon, if I did perforate this patient below the peritoneal reflection, below the rectum, it really isn't such a big deal. If I perforate somebody up above and perforate them into the abdominal cavity proper, then the feces and the bacteria can go into the abdominal cavity proper. But if it's below that peritoneal reflection, below the shrink wrap area, then it's really not such a big deal, and that can be treated conservatively. Or in this case, I chose to put a couple of clips on. Each of these clips is worth about $250 a pop. And you can see there's another polyp right there. But at this point, the pathology, the reason I'm burning this polyp, the pathology in this region is going to be determined by that large rectal polyp. Right away, I know that no matter what this is, assuming it's not cancer, this patient's going to get another colonoscopy in 5 years. Because I'm pretty sure that that's probably a villus adenoma, a large polyp. So here, again, I'm just putting another clip on to close what could be a micro perforation. Patient did fine. She'll poop these out in about 6 weeks. She won't even know it. They're smaller than a roach clip, like you guys used to smoke marijuana with in college. They don't act up. So here we're putting another $250 in the bowl. And that number will be important later. So anyways, that's the way we do it. Now, how do we do the surgery? Well, I've already told you that if it's anal, it's different than rectal. It turns out that the cancers usually spread upwards. They spread from distal colon up proximal along the lymph node pathway. It turns out that this is good for us because if you have a tumor here, I can take just a few millimeters past this tumor as long as I take more colon above, because that's the way it's going to spread. If it's spread actually distal towards the rectum, there'd be a lot of people walking around pooping in bags with colostomies. Because if you had a tumor here, and I had to get clean margins around that tumor by going 10 centimeters distal and 10 centimeters proximal, I would have to remove out to take the rectum. But this is the reason that we give people radiation therapy first, to try to shrink the tumor so we can get a clean margin here and take up more colon more proximal. So let me show you what this is. So here is a resection for somebody who has a distal colon tumor. Now this is rectal carcinoma because of that distinction between layman's terms of what the rectum is versus the anatomical term. But technically this tumor is in the distal colon because it's above the peritoneal reflection. So all I have to do is get below the tumor, and because we know that the cancer will spread proximal, I have to take a large margin proximal along with the blood supply to that region. This is the way that we treat the cancers. Here is for colorectal and anal cancer. If someone has a cancer here, and there's no way that I can preserve their contents, there's no way I can hook them back up, then I've got to take out the rectum and more proximal. And then all of this will be closed with sutures. So this is called an abdominal peritoneal resection. It's a big operation. So there's the tumor.
Does that result in colostomy?
Yes, it is a colostomy. So here's what colon cancer looks like. Of course, you've seen these pictures, I'm sure, from some of the pathology lectures you may have attended. This one here not only has a colon cancer, but it also has cancer on the other wall, and some of these have multiple polyps. Here's a polyp right next to the cancer. This is where it has spread to the liver, and let's go up here a little bit. So would I operate on a patient who's had all of this spread to the liver? If a patient came to me and had colon cancer everywhere in their body, and it was spread to their liver, all through the lymph nodes, would I operate on that patient? First of all, from what I told you, is if it's a distal tumor spread, it's a pretty good chance it's in the lymph nodes, pretty good chance it's in the distal organs. Right now it's in the liver, so it's a Duke's D. a bad diagnosis, but would I operate on this patient? Would I take out the primary cancer? The answer is, it depends. If the patient can't poop, then I've got to operate on them to prevent them from being obstructed. So I've done nothing to prolong their life, but I've made it at least so they can go to the bathroom. If they're 90 years old and they're in bad health and they smoke 5 packs a day, probably not. But if this is a 50-year-old person who is spread the liver and I can get this and it's accessible, I'll take it out to prevent them from getting obstructed. So that at least they can do. Here's what it looks like in the liver, colon cancer spread in the liver. Here's what it looks like on a chest x-ray. And here's what we call cannonball lesions, where it's spread into the lungs. So these are all bad signs, but none of these make 100% certainty that I would or would not operate on the patient. So now let's talk a little bit about FARA, because I got just a little bit of time left. Treatment of anal cancer. Surgery is no longer the recommended choice of treatment, and surgery is usually only recommended if all of the chemo and radiation therapy that we've done is unresponsive. So, Wayne State University, probably 25 years ago, this surgeon came up with a protocol that gave people with anal cancer the best chance that they had for a cure. And I use the word cure. 70% of patients can be cured of anal cancer. Chemotherapy and radiation therapy used to be followed by removal of the rectum. Not anymore. Now we give you chemo, radiation therapy, local resection of the tumor if we can. And if you have the chemo and radiation first, we can cure you. And this is where FARA made her mistake. Most of your tumors are epidermoid carcinomas. This is an abdominal peritoneal resection. So we remove the colon, the rectum, and the anus, and you get a permanent colostomy. So you're pooping through this bag the rest of your life. Now, the problem with FARA is when FARA was diagnosed with anal cancer, is that vanity killed FARA. FARA did have local excision, and FARA had radiation, but she refused the chemotherapy because the chemotherapy would have caused FARA to lose her hair. And why was FARA famous? Why was I in love with FARA? Because she was pretty and she had great hair, and she knew that. So the problem here is that FARA then died because she didn't have chemotherapy because she didn't want to lose her hair. This is true. So what we saw, did anybody see the special on television that FARA did? Did anybody watch this? FARA miseducated millions of people with that television special because FARA's foundation seeks alternative methods of cancer research. FARA hopped an airplane, and I think she went to Sweden. Was it Sweden? And she got intra-arterial infusion of chemotherapy into her liver. And in that special, she said, the reason I'm getting on my Learjet and flying over to Sweden is because they don't do this in America. But there's a reason we don't do this in America. Because we know it doesn't work. It's been tried before. It doesn't work to cure the metastatic disease to the liver. FARA's problem was all she had to do was initially get local excision, radiation, and chemo. And there's a pretty good chance, of course I wasn't her doctor, but there's a pretty good chance FARA would still be with us if she had done that. Then when it recurred, and it recurred around the anus, they offered her the abdominal peritoneal resection. They offered her this. She said no. That's when she hopped the plane. And from my point of view, her destiny was sealed the minute that she refused the chemotherapy to keep her hair. Now, the Farrah Fawcett Foundation, which I would never give money to, just because I think she's doing the wrong thing here. But what Farrah did is they gave licensing to Mattel products to make a Barbie doll. And the Barbie doll is, of course, advertising her hair. They do make Barbies, believe it or not. Let's go back here to, I think it's right here. So why doesn't Mattel make this? So women who have breast cancer, colon cancer, pancreatic cancer, they get chemo, they lose their hair. In America, for some reason, because of people like Farrah, there's shame associated with a bald woman wrapping her head up who went through cancer treatment. And that's just stupid. You know, your hair will come out. Who cares? I mean, wear a wig. I mean, you could be alive or dead. But Farrah shamed millions of women and made them afraid to lose their hair. And of course, the point of this is how come, Mattel doesn't make a bald Barbie?
They did.
Do they?
They just started, I think, last year.
Maybe it's because of that. So if you actually want to look at this, you can actually go to Farrah Fawcett Foundation and look up where they spend their money and where they get their money. Most of Farrah's money came from her estate. And whereas the American Cancer Society, if you look this up, you can see where this goes to research, this goes to funding of NIH grants, this doesn't. So before you give money, make sure you look things up. Now I'm almost out of time. Will my insurance company cover my colonoscopy? The answer is maybe. It depends on how your doctor codes it. Every time we do something, we have to fill out one of these forms, and it has codes on it. It's all about the money. It's all about the money. The insurance company doesn't want to pay for screening colonoscopies for everybody. Here's the catch. Your insurance companies will tell you that they will pay for screening exams. They will pay for screening mammograms. They will pay for screening colonoscopies. But the minute, now this isn't all insurance companies, but some of them, the minute that I put the colonoscope up your rear and find a polyp, it now has become a diagnostic colonoscopy and they won't pay for it. Even though you walked into my office because you're 50 years of age for a screening exam, the minute that I find a polyp and send it to the pathologist, now I'm looking for a diagnosis of that polyp. It is now a diagnostic exam, and usually they won't pay for it. So, read the fine print. Now, how much did I get paid to do a colonoscopy? Here's Medicare. Medicare pays us based on this crazy formula. There's a good story here. There is, you can figure the formula out. My wife wants to do this, I don't. But there's a conversion factor of $34. What this means is, if you look at this as a percentage, the normal conversion factor for anything we do in my office would be 1. So Medicare, this is a 0.34. It's a dollar sign in front of it, a 0.34. Medicare pays 1/3 of what the cost is. Okay, notice the way I word that. Medicare pays 1/3 of what the cost is. Not 1/3 of what I bill, they pay 1/3 of what the cost is. So here's what I got paid to do a colonoscopy on a Medicare patient. If it's a diagnostic, if I have to send a polyp off, I got paid $209. If it was a screening exam and I didn't find any polyps, they allow $219. I get this, I get 80% of that, and the patient pays me the other 20% of this number. $175. Is that worth it to me as the doctor to run the risk of perforating your colon, even though that risk is small? Is it worth the risk of putting you on the table for $175? Remember, this is before taxes. This is my number. This is what I get paid before taxes. So the reason I love this story is because it goes back to this. When they were trying to figure out what kind of watch that they would wear on the moon, they put all of the watches through heat, vacuum, all of these tests. They put Bulova, Rolex, Omega, Timex, they put them all through the test. The only one that passed the test repeatedly was an Omega, which is what I'm wearing. Anyways, it's the only one that passed the test. So Bulova got pissed. Bulova said, you said you wouldn't send anything to the moon that wasn't American made. So Omega said, okay, that's fair. So they took all their parts and they mailed it over to America, and the watch was assembled in America. And they tested it again against Bulova watches, and Omega still won. So what would the U.S. government pay Omega for their watch? So let's assume it's a $1,500 watch. I don't know. Because of the conversion factor, you can't sell anything to the U.S. government and make a profit. Same thing is true of our colonoscopies. You can't do anything to the U.S. government and make a profit. It's illegal to make a profit off the government. Bolivar decided to forego all of that, and they charge them $1. And of course, in return, they get to tell everybody that they're watching. So this is the way our Medicare system works. Just thought you know. So that's it. I made it right at 1 o'clock. Any questions? Comments? Thank you for attending.